Good evening. I was asked to have a group discussion on pancreatic surgery. Pancreatic surgery is a very vast topic, but at the MS level or the DNB level, I don't think we should worry too much about all the great intricacies of the surgery because it is difficult surgery, fraught with many challenges. But I think we should all understand some basic principles when we deal with the pancreatic surgery. Before I go with the actual topic, can somebody read this CT for me? Nikita.
Sir, it's a CT of abdomen and pelvis in a coronal section, sir.
Where is the pelvis in this?
Yes, I'm sorry, sir. At the level of lumbar vertebrae, sir.
Yeah, what kind of lumbar vertebrae? When you see the kidney, where would you think it is?
Kidneys, yes, sir.
Yeah. So what level is it?
At the level of L2, sir.
Yeah, L1 or L2, I agree. And is it coronal? You must be very careful when you use your words.
Yes,
transverse section. So what else have you to say about that? One other technique. Contrast enhanced or plain?
It looks plain, sir.
Plain. Why, Nikita, you're not thinking?
Because
what is this?
delayed, sir.
Some background noise. Can somebody start correcting this, please? What I'll do is make Sanya a co-host. So please mute people if there is a disturbance, Sanya.
Yes, sir.
You know, what is this? You know, this is a transverse section of an abdominal CT. What is this structure? Can you see my pointer?
Yes, sir. That is aorta, sir. Abdominal aorta.
Is it white or is it isodense?
It is.
Why would it be white?
It's not relatively more white, sir.
Yeah, why is it white?
Because of contrast.
Yeah, contrast is given. So this is a contrast enhanced CT, a transverse section at the level of L1 or L2. That is where you will see other structures. So what do you see here? This is the liver. Liver looks normal, spleen looks normal. Stomach, you may call it a little dilated. There is quite a big gastric air bubble. And what is this?
Pancreas.
Yeah. So what is remarkable about this pancreas?
Duct calcification.
Sir.
Yeah. Where? Calcification where?
Ductal calcification.
Along the ducts.
Ductal. Only that? Central means duct. Central means duct. And anything else?
Tail region also.
The tail.
This, you think this is stones in the tail of the pancreas? I mean, I wouldn't blame you if you said that. Yeah, but it could be contrast in the gut also. It seems to be a little outside this. This is the edge of the pancreas, as you can see.
Yes,
this seems to be a little outside, and it's a lot of dense kind of contrast. So it's more likely to be a bit of contrast in the colon. Okay, this is the stomach, right? So this is pancreatic ductal dilatation with ductal calculi. So where would you find that?
In case of chronic pancreatitis.
That's all. No great shakes. It's a chronic pancreatitis. So what I'm going to do today is discuss with you a very brief outline of the history, because I find it fascinating the way pancreatic surgery developed. I won't ask you questions on that. Then we look at the kinds of resection that one can have for both chronic pancreatitis and neoplasms, both benign and malignant. We'll talk about some salient technical points that one should bear in mind, and expected complications, and very briefly how one would deal with those complications. Okay, that is the plan of action. I'm not talking about anatomy, physiology, not really in great detail about indications and contraindications. You will talk a bit about it when we talk about resectability, which is a different, related but a slightly different aspect of pancreatic surgery. And so let's move on. See, it's interesting that the beginning of pancreatic surgery was actually through cholecystectomy, right? For stone disease, the first open cholecystectomy was recorded in 1878. And when they couldn't take it out, there was a problem, cholecystostomy, not, it was an external drainage of the gallbladder. And when they found that was a nuisance, somebody put the gallbladder to the colon. As you can imagine, that is fairly disastrous, with a great lot of infection and a lot of morbidity. And then they felt, colon is not a good place to put it in. So they put it into the jejunum with a lot more success than the gallbladder to the colon anastomosis. Coming to the pancreas proper, the first distal pancreatectomy was done in 1886. Head resection without much success was done for a mass in 1898. But then because of the mortality and the difficulty and the complications, nothing happened for about 5-6 years, when people thought we should have a better way of taking out the head. And then Cocker described the classical duodenal mobilization. That seemed to make it a little more easy. And 6 years later, they then said, we will do it in two stages. In the sense that they took out the head and left the pancreas to drain freely, and then the patient survived the first part. They went ahead and did the pancreatico-jejunal anastomosis at a second stage, a few days later, if the patient survived. That need not be stressed. So that's when the pancreatic stump was exteriorized. That's the point I make here. They even before that tried to suture off the distal part of the pancreas when they had done the head resection, again leading to disastrous consequences, severe pancreatitis and mortality. And much later, we have found the real successful head resection with reconstruction. Even Whipple did it in two stages in the beginning, but then he had the one who got away with a reasonable mortality. And somebody tried even before that enucleation for small tumors as early as 1927. Please remember, even though we named the operation of the pancreatic duodenectomy after Whipple, he had 37 cases in his series, not a huge series, and he had 33% mortality. One in 3 died. Between that time, in the 30s to 70s, there was very little progress. People were occasionally doing it. Then they felt that they should have a pylorus preserving thing brought in by Longmire to avoid dumping that one normally saw here. In the 80s, of course, the two concepts that hold good even today were that you must have a good post-op care, standardize the intraoperative technique, and you must have a high volume. By definition, what is the definition of a high volume center? Let us, more than a high volume, let us say, what is the minimum volume they say you should do before you undertake Whipples?
Sorry, sir.
Sorry?
I don't know, sir. Sorry.
Guess. I'm not even talking about a high volume. High volume, do it in hundreds. But what is the minimum? If you are even attempting a Whipples, the general thinking is that you must do a minimum number per year. What is that number? I can tell you none of us do it.
20, sir? Is it 20?
10. It's 10 a year. But real high volume centers do 200 to 300. 200 to 300 a year. I saw a morbidity, a review article across the United States where they had reviewed centers with as little as 3 Whipples a year to 237 Whipples a year. That is the kind of numbers that some centers have. But if you have a high volume center, you will end up with a very low mortality. Look at this 33% and look at the 5%. Okay, then we had developments not necessarily in the technique of the surgery, but then things like CT, vascular resection and reconstruction, minimally invasive surgery, robotic surgery, and as a parallel for neoplasms, some progress in neoadjuvant chemotherapy. Okay, so we'll discuss all these in detail as we go along. Okay, so if we're thinking about surgery for chronic pancreatitis, okay, who do you think should have surgery for chronic pancreatitis? Vinod.
Sir, severe pain and when it is localized to somewhere with the
Localized
ductal
where?
dilatation.
He won't tell you I have pain in the duct. So intractable pain, there is a rider for that. I agree with that, but there is a rider for that. Any person who comes to you with pain with chronic pancreatitis, would you operate on them?
No, sir.
What is the rider for that?
The ductal dilatations and strictures in between, which is causing the pressure, is because of.
No, you're all going to pathophysiology, but what is the characteristic of that pain? So you told me you would not operate on a person who just walks into your clinic and says, I have pain, and you detect ductal dilatation and calculi and strictures. Would you operate on him straight away?
No, sir.
So when would you operate on him? Do surgeons operate on every case that they see?
No, sir. Depend. Patient is
So
completely dependent on drugs for pain.
there is something called conservative treatment, right?
Yes,
So
sir.
what is the conservative treatment for chronic pancreatitis? You would try it out first before you operate. What is the conservative treatment?
Painkillers are first, like tramadol.
All right. You're giving a narcotic straight away, narcotic analog. The step ladder pattern applies to this also. But before that, what do you do to address the pathology? Pain is, you're not addressing the pathology. What can you do to address the pathology? How do you rest the pancreas? How do you deal with the associated conditions with pancreatitis?
Yes, sir. We'll give
You guys
small.
must read and come. These are all. I've told Sanya, you will know what I'm discussing. I said, you must read up and come. If I keep spoon feeding you with a presentation, however good that presentation is, you will remember only 10% of it 3 months down the line. Do you understand that? Yeah, that is science that is well established. All right, because if we go at this rate, we will not cover even 1/3 of our presentation.
Keep the patient nil per oral.
No. The conservative treatment involves reducing associated gastric hypersecretion by giving PPI and by resting the pancreas with pancreatic supplements. These are the two mainstays. Nil per oral is for acute pancreatitis. Chronic pancreatitis, how long will you keep him nil per oral? So you give this for 3 to 6 months, and if it doesn't respond, that is intractable pain, you then offer surgery. Okay? Common bile duct obstruction, there's fibrosis associated with it. There can be a pseudocyst that lasts, which is bigger than 6 centimeters and lasts more than 3 months, for example, or gets complicated in terms of bleeding or infection. Pancreatic ascites. How is a pancreatic ascites different from pseudocyst? Praveen.
Pancreatic ascites will be of enzymes, rich in enzymes.
Yes, but how is it different from a pseudocyst? There is no great trick in this. I never ask trick questions. How is pseudocyst different from ascites?
Sir, pseudocyst is a collected form, sir.
It is localized.
Localized. Yes.
This is more diffuse.
Yes, sir.
All right. What is the underlying pathology for pancreatic ascites? Why do people get pancreatic ascites?
Due to pancreatic duct injury.
Which duct?
Major pancreatic duct, sir.
Correct. Major pancreatic duct has to be disrupted because of pancreatitis and inflammation. Only then you get ascites. You can have duodenal and colonic obstruction. You can have pseudoaneurysms. You can have venous thrombosis. So all these are, and of course, suspicion of pancreatic adenocarcinoma. can you for sure, with all the investigations we have at our disposal, can you for sure differentiate between carcinoma and a carcinomatous mass and an inflammatory mass? Can you get 100% diagnosis?
Not 100% most of the
Okay.
times.
How much can you? What is the degree? What is the degree of confusion?
Maybe 10%, sir.
Correct.
I
About
think
in-
it's around 90%.
Correct. In about
sensitive.
10% of cases, with all the things at your disposal, you will not be able to differentiate whether a mass is a carcinomatous mass or a inflammatory mass. All right. So these are the indications for surgery. And what are the kinds of operations that you can do for chronic pancreatitis? Nikita. Before that, what are the theories, which major theories, just list them, that give you the pathogenesis for pain in chronic pancreatitis?
Pathogenesis of pain would be because of stones, sir. First,
Stones per se?
inflammation of pancreas. Could be the first one.
Inflammation is one, correct?
Yes, sir. And because of the stones and obstructing, there could be increased pressure within the pancreas.
Ductal hypertension, correct?
Yes, sir. And maybe landing up in complications like pseudocyst, necrotic cyst, ischemia, sir.
Causes infection more than
Yes,
ischemia,
complication.
agreed,
Yes, sir.
infection. And
And strictures,
strictures and hypertension are all the same. And there's one more theory. When there is
Yes,
pain, nerves must be involved. So what is the neural theory for the pain? Either inflammation or the fibrosis affecting the nerves in and around the pancreas, including the celiac plexus. Okay, ductal
Yes.
hypertension, inflammation, infection, and neurogenic. So when you
Yes.
when you offer a solution for this, you address each one of these. All right. So how are you
Yes, sir.
addressing it? What are the operations that you can do?
Sir, if there are stones, we will go either for lithotripsy or removal of stones.
Okay.
And it depends upon the pathology, sir. If it is
Yeah.
inflammatory or
No, just list them.
pseudocyst-
I'm giving you the answer here. Okay. So just list what are
Yes,
the
sir.
things that are available to address all these issues.
Yes, sir.
If you have ductal hypertension, what can you do? Relieve the hypertension, either by an endoscopic
We
method.
open the duct. Yes,
I mean, that is by surgery. But before that, you can put a
Yes.
stent in the pancreatic duct. Okay, you can
Yes.
put a stent and reduce the hypertension. Try and clear the stones in the pancreatic duct by what? Lithotripsy.
Lithotripsy, external
Yeah,
shock
you
wave
can do a
lithotripsy.
external shock wave lithotripsy, and then those short segment things, you do a pancreatic duct sphincterotomy, and then put a stent to do that. That can be done. All right, and if endoscopic thing doesn't work, you can then address the ductal hypertension by opening up the duct, opening up for the whole length,
Surgically.
release the strictures and then drain it so that there is no hypertension. Or if there
Yes,
is
sir.
a lot of inflammation which you cannot control, then you can do a resection of the pancreas. All right. So with these basic things which I have given you the algorithm already, the important thing to remember is a condition called autoimmune pancreatitis. I won't go into it, but it is associated with IgG4 immunoglobulin. It can be a part of a systemic disease where you have many other autoimmune processes going on. No surgery for it. And as a contrast to all other kinds of pancreatitis where steroids can actually induce pancreatitis, this is an exception where steroids and other immunosuppressive therapy actually helps in pancreatitis. That's a medical condition, but you must be aware of it even as a surgeon. The important thing is when you have only ductal dilatation without a mass formation, then you can think about the lateral pancreatic projection ostomy. Just laying the duct open. And if you have a mass lesion, then you might have to think about this procedure called the Frey or the beggar's procedure. And if none of that works, okay, and if there is extensive parenchymal calcification as opposed to ductal calculi, okay, ductal calculi, if you open up the duct, you take it out and then put a loop of jejunum on it, and then they get better. But if there is parenchymal calcification, which means the inflammatory process is very high, then you have no choice but to do a total pancreatectomy, followed by an islet cell transplantation. Okay, these are the broad outlines, and I want you to understand the broad outlines first before we go into specifics. So we have given you the answer. So just give me a list of operations that you can do for chronic pancreatitis.
Sir, lateral PJ, phrase, biggers,
Okay,
total pancreatectomy, distal pancreatectomy.
correct. All right, agreed with that completely. Fustos, lateral pancreatic jejunostomy. So we want to preserve the duodenum. You don't want to take away the Whipples, which Whipples is an option, but it has a higher morbidity. So you do the Frays and Beggars, and then you may end up then having to do a distal or a total pancreatectomy. Okay, that is this course of events. So here is your list of things that you do. If there is a mass lesion or if there's a suspicion of malignancy, do not go for only drainage of the duct. You must do either a Whipple's pancreatic cord duodenectomy or pylorus preserving pancreatic cord duodenectomy. Head mass with a dilated duct, you can do a Beggar or a Frays procedure. There is a burn modification of the Beggar, and I'll show you a picture of that so that you get an idea of what it is. Head mass with small pancreatic duct, Hamburg modification, which is a kind of an expansion. You cut a wedge of the anterior pancreas onto the duct so that in effect it becomes a bit bigger, and then you can do a pancreatic jejunostomy. Dilated pancreatic duct with no head mass. This is one of the commonest conditions that we see. You do a fused toe and its modifications. Small pancreatic duct with no head mass. Again, this is a modification of this pancreatic head mass with a small pancreatic duct. So it's a modification of that to drain the duct. Hereditary pancreatic syndromes and diffuse parenchymal disease. This is the calcification I was talking to you about. You do a total pancreatectomy. Okay, those are the choices that you have for chronic pancreatitis. Fustos procedure. All right, Praveen, tell me what are the major steps in a Fusto?
Sir, in this
We're supposed to talk about technique of what. That's why I'm talking about this. Yeah.
Yes, sir. We'll be giving opening along the anterior surface of pancreas.
How do you reach the anterior
tail to
surface?
tail.
How do you reach the anterior surface of the pancreas? Why this great silence?
Through the lesser section.
To the lesser side, gastrocolic momentum, you open it and you're on to the anterior surface. You may want to do a bit of cauterization. If you're doing anything with the head of the pancreas, it's always good to cauterize the duodenum. Do the whole length, see the whole length of the pancreas from the head, neck, body, and tail. Okay, then what do you do?
Sir,
We'll
identification
be
of the
doing
duct.
the
Sorry,
Identification of the duct, sir, pancreatic duct.
how do you do it?
Maybe like if chronic, it will be dilatations. Like if there is a stones, we can palpate it.
Yes,
Otherwise, we can with the syringe we can.
with a needle. You
Yes.
can poke with a needle and see if you can hit a duct, correct? And then you open that. Once you make a little opening, then you can put your
Jejunum.
yeah, not jejunum. You put your artery forceps or even a mosquito. Put it across the duct, open it up completely, clear all the open up the strictures, clear all the stones, and then how do you put the jejunum onto it?
Side.
Yeah, you will do a rule loop.
Suffer
Do a rule loop and put a jejunum onto.
Yes.
Okay, a rule loop onto the duct. Now you can do it only if you have large ducts with multiple strictures and stones. You do not do a pusto if there is an inflammatory mass in the head. small duct disease. There's a small modification that I mentioned about where you open up the anterior surface of the pancreas which is sitting on the duct as a wedge. And so in essence, you are converting a small duct disease to a larger duct disease. But by and large, you're right to say that you do not do a pustosis with a small duct disease. When I was a student, the minimum diameter they mentioned was 10 millimeters. You are not allowed to do a pustosis if the duct was less than 10 millimeters. Today, it is down to 6 or 7 millimeters. Okay, they say that it is good enough for that. Now, what is the kind of response that you expect from pustosis? What is the mortality, morbidity? What is the success rate? How does it work?
Leak is the morbidity, most common.
All right. Very low mortality. Leak is a morbidity, but again, not very common. Infections can occur. You can have a leak essentially means a pancreatic fistula at that stage, but very high pain relief, 95, some people even say 95%. What is to be noted is that a third of them recur. So when you offer this surgery, you cannot say you're cured forever. All right. If they continue to have alcohol, which is again the commonest reason for chronic pancreatitis, the recurrence rate is even higher and faster.
Sir, why is it recurrent?
Recurrence in pain. That's what I meant. I didn't mean recurrence in tumor. This is chronic pancreatitis. Okay. So recurrence of pain. The effect, the chronic pancreatitis has its own mind, as it were, and the process keeps going. Even if they're completely abstinent, even if they stop alcohol completely, it doesn't completely reverse the inflammatory process. If they continue to take alcohol, which happens very often, then this inflammatory process, compounds and accelerates. So there's a high failure rate. But even if somebody behaves perfectly well, the good effect of this lasts only 5 to 10 years. It is not forever. So it would be wise to tell them to really keep off alcohol and give them the realistic prognosis that one can expect. Okay. And there is a big debate as to whether there is an improvement in the exocrine and endocrine function. The major indication for any operation for chronic pancreatitis is pain. Concomitant with pain, you also have both exocrine and endocrine deficiency that may or may not improve. There is a controversy about it. There are some papers that say that if you operate on them early enough, you can slow down the deterioration of the exocrine and endocrine function. There are others which counter that. And so it would be wise for us not to commit ourselves as far as the function of the pancreas is concerned. All right, so this is the realistic output from a pustosis procedure. Why are we talking about it? When you offer this to your patient, you have to mention these things to get an informed consent from him. And that is the kind of learning that you have to do, not just the technique of doing the operation. All right, that's important. Now, this is exactly what you do. You cut the whole length. One of the common mistakes that many surgeons do is open up just that little bit where the stone is, leave the rest. Not correct at all. Wherever the stone is, whatever the area of the stricture is, you must lay open almost all of the duct and do a long lateral side-to-side pancreatico-jejunostomy. All right. Phrase procedure is when you have a mass lesion in the head of the pancreas. Here you do what is called a coring. So you can see that in the picture sort of looks a little similar on both of them, but actually in phrase you do a regular coring of the head where you take out a lot of the head part of the pancreas, making sure that you do not breach the posterior wall. This is where cauterization is important. You cauterize it and have your left hand behind the pancreas and then start coring the head of the pancreas. And once you have the whole thing, you do a similar pancreatic jejunostomy, but with a big coring, as I said, big defect in the head of the pancreas, where you're physically taking out the inflammatory mass. The Beggar's procedure, the original Beggar's procedure was like this. It is basically a duodenum preserving procedure. And when you want to preserve the duodenum, you must make sure that you preserve the posterior branch of the gastroduodenal artery. The gastroduodenal artery comes at this point, has an anterior and a posterior branch. When you take out nearly the whole of the head of the pancreas, you will eventually have to take away the anterior branch of the gastroduodenal artery, which comes around this point. Are you seeing my pointer?
Yes, sir.
Yeah, around this point. But there is a posterior thing which goes behind the duodenum. If you preserve that, the duodenum does not become avascular. And please note that in the original Beggars, you are actually transecting the neck, which means that the dissection in this part above the SMV is similar to what you do in Whipple's. All right. But here the duodenum is preserved. And you drain it like this. In a classical Beggars, you take the same loop of jejunum, and instead of putting it laterally like this, he would invaginate the pancreatic remnant into the end of the jejunum, and the side here would be anastomosed to the remnant of the pancreas that is left there. The burn modification is where they would not transect the neck. Okay, transection again means a little more morbidity. So they would not transect the neck there. So it is actually, it ends up being a little more vigorous phrase procedure. So the burn modification, you take out a lot of it, but the posterior part is still intact. So that is almost like a big phrase. And that is the burn modification of the Beggar's procedure. Okay, so it begs the question, when you have all these procedures, which works better and in what sense? So any guesses? Has anybody done any reading? Sanya, have you done any reading about this? If you're
Sir, I
not,
read about the procedures, but I don't know the
yeah,
comparisons.
outcomes are
Statistics.
very important. You know, when we choose a particular operation, we have to know the outcomes, and then give those data to the patient before you and the patient together decide what is best for them. So if you guys can't, I'll tell you the literature on this. Okay. So the factors that we normally measure when we look at outcomes in pancreatic surgery in general are mortality, morbidity, and pain relief. Okay. The degree of pain relief, the number of people who get the pain relief, and the duration of pain relief. There are actual data and big tables. I did not want to bore you with those data, but the final conclusion is that Frey is better than Beggar, and Beggar is better than Whipple's. Okay. And at the end of a few years, for example, 1 or 2 years, all long-term results are the same. So your pain relief and morbidity are the same in many of them. Frey is probably better than Beggar because the mortality of Frey is less than that of Beggar, and the mortality of Beggar is less than that of Whipple's. So if you can easily see that, if I have not done a Beggar at all, based on this, whenever I find a mass lesion, inflammatory mass lesion, I have done Freys before, but I have not even offered them Beggar or Whipple's. Now, can I bring Ravi here, and then, your comments on what we have discussed so far, Ravi, please.
No, sir, I think it's all very clear. The indications and exactly when there is pancreatic mass, when there is no pancreatic mass, after dilatation, I think you outlined it very well.
All right. Okay, any other comments or questions from the students, please?
Sir, regarding cauterization, sir.
Yeah.
For even for lateral PJ, you require cauterization, sir?
No. Whenever you're dealing with the head of the pancreas, you need cauterization. And when I said no for this lateral thing, I'm not completely correct. If you have a lot of dilatation, a lot of stones in the head of the pancreas, even without a mass, when there is mass, you do Frays. When there is no mass, but you can still have stones and dilatation of the duct in the head of the pancreas. If that happens, you have to cauterize, because without cauterization, your control on the head of the pancreas is limited. So it's good to have it's a very simple procedure. You must have seen it. It's very simple to do that, and it's good to have good control because you can get your left hand behind the head of the pancreas, behind the duodenum and the head of the pancreas, and you have better control on your operating.
Yes.
Okay.
Yes.
All right, can we proceed? All right. Now, there are some complications of pancreatitis which also need surgical attention. Okay, what are the things that you can think of? Complications that need surgical attention. We told you earlier,
The
Pseudocyst,
pseudocyst.
pseudocyst.
necrosis.
All right, that's acute again. Yeah, more than that. It's not a complication of chronic pancreatitis. If you have chronic inflammation, what can it do to the surrounding structures?
Fibrosis.
Yes, so fibrosis leads to what? Correct. Fibrosis leads to what? So,
Adhesions.
not adhesions, fibrosis. If you have fibrosis in stricture of what?
Duodenum.
Duodenum, okay. What else?
Duodenum.
Bile duct.
colon.
We even listed it, in one of the previous slides, we had mentioned it in the indications. Okay, colon can get stricture, duodenum, bile duct, and the inflammatory process can do something to the blood vessels. What can happen?
Thrombosis, sir.
Yeah,
Thrombosis.
yeah,
Aneurysm.
Aneurysms.
yeah. Pseudoaneurysms and thrombosis. In a chronic thing, okay, the duodenal and colonic, they're all very rare. But what is a lot more common is splenic vein thrombosis because of the inflammation that leads to a so-called left-sided, what is it? Portal hypertension. Left-sided portal hypertension, when you may have to do a splenectomy. All right, that's one of the indications for that. But CBD obstruction is a lot more common. And I write here again, rule out autoimmune disease because every pancreatic CBD obstruction is not because of, only the conventional pancreatitis. It could be autoimmune and it will be disaster if you operate on them. So you must rule out autoimmune disease. And what do you say? One of the common things that we measure for autoimmune?
IgG.
IG?
G4.
G4, correct. Just remember that, and that's more than enough, at a DNBMS level. So that is something we have to rule out before you do something with the drainage. And the drainage takes the form of hepaticojejunostomy or a choledochoduodenostomy. Depends on how much of the peripancreatic fibrosis there is. If it is restricted to the pancreas, for example, your duodenum is supple and the common bile duct is not involved, in which case you can do a choledochoduodenostomy. If you have extensive peripancreatic inflammation as well, or the after effects of a pseudocyst around the head of the pancreas, for example, then you have to go further away from the pancreas to do your anastomosis, in which case you have to do a hepatic duct, not bile duct, but hepatic duct to the enteric anastomosis. Hepatic duct is far away from the duodenum. So you don't want to put any tension in that anastomosis. Duodenum will not be very mobile because of the same fibrosis. So you end up with a Rouen loop hepaticojejunostomy. See, it is so simple, isn't it? When you think about it and you sort of analyze why we do these things. So when there is a lot of fibrosis around the head of the pancreas, you have to go far away to get a supple hepatic duct, not bile duct. And when you're far away, you need a longer loop of bowel. And so you end up with a hepaticojejunostomy. All right, this is the complication. This is the surgery for complication of pancreatitis. Now we go on to the operations for neoplasms. But before we actually get into it, imaging is extremely important. And so I need you to tell me what are the common modalities of imaging for the pancreas. Just list them.
Sir, for malignancy, sir.
Yeah,
CCT,
Triple plus CT.
abdomen pelvis,
CCT, okay. That is
MRCP,
the
sir.
investigation of choice. Yes. MRI and MRCP. Good.
Endoscopic ultrasound.
Yes, very good.
US, yes, sir.
US.
And so can we consider
ERCP.
ERCP also as an imaging, sir? Because
Yes,
it also
yes. Why
is
not?
monitored.
Why not? Yes. ERCP and PET CT.
Finally, PET CT.
PET CT. Okay. I have left some of them out, but these are the things that you're trying to decipher when you do any investigation. Okay. You want to get a diagnosis of the primary tumor. You want to determine whether it can be resected or not. Instantly, if you look at the whole series of pancreatic neoplasms, what percentage you think is resectable?
10%, sir.
Yeah, 10 to 20 at the most. Okay, 10 is the more common thing. Yeah, most of them are not resectable. Distant metastasis, not resectable. And later on, once you have done a resection or given any other treatment, you need to monitor it. Okay, see whether how the response of the disease is, whether if you're giving palliative chemo, whether it is reducing in size, if you've done a resection, whether there's a recurrence. So these are the main reasons why we do imaging of the pancreas. And when you do imaging, then I have not included PET CT in this, I have not included ERCP, because they are not the main ones that are the primary concern for a surgeon, because PET CT is debatable and ERCP is perhaps considered for palliation rather than getting information about the resectability. So in diagnosis and determining resectability, the three main modalities are the CT, the MRI, and endosoma. Okay, and this lists the importance of each of these, but I didn't ask you, just describe the first two lines of this slide. Praveen, tell me, what are these things? What do these things mean?
Triphasic will be both arterial, venous, and
Delayed.
Yeah. Okay, that is arterial, venous, and a delayed phase.
Delayed phase.
Yeah, thin section.
And,
No
smaller
great.
sections.
Yeah, you take it closer. The sections
Closer
are taken
sections,
very
yes.
close to each other. CE,
Contrast enhanced.
yes, MDCT, multi-detector. That's the technology of the machine involved.
Yes, sir.
Okay,
Multi-detector
yeah,
computed
yeah,
tomography.
yeah, and 3D reconstruction. Reconstruction is done by software. The CT captures the image, but the software does the reconstruction. That is very, very important for what? This reconstruction is useful in telling you what information?
Clearance, sir, during the process.
No?
In surrounding involvement.
Anatomical structures.
In the
Yes, sir.
anatomical structures, you have the answer on the, you only have to choose.
Vascular.
Correct.
Vascular
That's
involvement.
correct. The determining thing for resectability is the vascular anatomy. Okay. The vascular anatomy and involvement is what you determine with the CT. How important is the lymph node involvement?
Peripancreatic lymph nodes, if involved, can be resected. No, sir. Is
Okay.
it considered resectable?
Yeah.
But if it is involving beyond that,
Yeah.
then might not be operable.
Yeah.
Can be
That
considered
is the correct answer. I'll tell you a little bit more about lymph node as we go along. But yes, when we were training, for example, when we were training 30 years ago, if a lymph node was found involved, we would even do a frozen section on a lymph node, peripancreatic node. And if it was positive, it was deemed futile to do a Whipple's. Today, the thought is that even an R1 resection is worth it. It need not always be R0. Okay, so that is the change in the recent decade or so. Obviously, if you have a distant spread, you won't operate. If there is a gross involvement of vascular anatomy, you do not operate. But for you to get sensitive information about the tumor, it usually has to be about 2 centimeters. Smaller tumors, primary tumor its size is better picked up with endosono, but it is observer dependent. Like any other sonography, it is observer dependent. The advantage of endosono, of course, is that you can do an endosono directed FNAC of the mass on the head of the pancreas. But even if you do all that, as we mentioned earlier, in 10% of cases, you will never have a complete answer. MRI is coming more and more closer to CT. It gives you similar information, and the information gained from MRI and this is called a special pancreatic protocol for the CT. It's not done like any other CT of the abdomen or pelvis. There's a special pancreatic protocol, and this is the description of that pancreatic protocol. Okay, so MRI today is coming along with the MRCP, which is taken, it's a part of the whole process. Now comes very close to the CT as well in giving you that information. Okay, and this is a table which you need not bother about. You will see that the accuracy is best in endosono. Okay, it's best there. Still, the commonest investigation is the CT. Okay, even though it is not the best, it's actually perhaps the least of the three, but it is easily available, a lot more standardized. MRI, not easily available and expensive, not commonly read as also, so it's not become very popular, even though it is getting there. Endosono, least available, observer dependent, but if you have the right institution and the right person doing it, it gives you the best information for CA. Okay, that is about imaging. I spent this much time on imaging basically because this is very crucial before we take a decision to operate. Okay, so we mentioned that this is important for staging and resectability. So what are we looking at in this?
First, the location of the tumor or
Correct.
mass, whatever you're looking for,
Okay.
and the extension, sir, from where to where it is extending.
Yes, its
Then
size.
yes, sir, and the involvement of surrounding structures.
Yes.
And the vascular components which are involved.
Okay.
Then we'll be looking at the lymph node status.
Yes.
And then of the liver, there are any mets,
Okay.
or any other organ, mets within any other organ in the abdomen, or ascites, the presence of
Very
any
good.
ascites.
That is quite comprehensive. That is all the things that you're looking at. When you look at the vascular involvement, what are the things that you're looking at?
Involvement of arteries and veins.
Iliac
Sir.
axis
Okay, which ones?
Superior
Superior
mesenteric
mesenteric.
artery,
and
common
superior
hepatic
celiac.
artery,
One person. Vinod, yeah, go on.
common hepatic artery, celiac plexus, superior mesenteric vein, and superior mesenteric artery.
All right. So what makes it unresectable?
If artery is involved greater than 180 degrees.
Correct. All right. And
Vein.
have you looked at the staging that is put out by NCCN about what makes it resectable? There are 3 classes:
Resectable,
borderline, and non-resectable. Correct. So how do you define these?
If this,
Anyway, we'll come to that in a minute. Okay, here, this is it. If any vessel is involved to less than 180, which is half, it is called abutment. That is the word they use. If it is more than 180, it is called encasement. When there is encasement, you do not operate. Lymph node involvement, less important than earlier thought. So even if there is some lymph node involvement, you go ahead and resect. Of course, if there are surrounding structures, you can do en masse or en bloc resection, which is now considered acceptable. Distant metastasis, no resection. But here the main thing is to understand the terminology for vascular involvement. Okay, so when you dissect, when you talk about resection, okay, these are the options that you have: enucleation, central pancreatectomy, distal, Whipple's, and total. So can you just describe in two sentences what each of these means? Nikita.
The enucleation refers to only the resection of tumor, sir.
Removal of the
Without-
tumor with the surrounding rim of normal pancreatic tissue.
Yes,
All
sir.
right, yeah. Central pancreatectomy,
Only the central portion, like
yeah, you leave the body and
cylindrical, yes.
tail behind, and
Yes,
you
sir.
leave the head behind, but the tumor, for tumors in the body of the pancreas, you can take out the central portion of the pancreas. That's quite feasible. I haven't done one, but it is feasible. I haven't found a patient or a case to do that. Distal pancreatectomy,
Would be the resection of only the distal portion. If the
what is
tumor is
the,
present in
what,
the
what
distal.
by definition, what is
Along
it?
with spleen, yes, sir.
Anything to the left of the neck of the pancreas. All right,
Okay.
body
Yes,
and
sir.
tail, anything to the left of the neck of the pancreas. When you take it out, it is a distal pancreatectomy. Whipple says pancreatic duodenectomy.
Yeah.
Total is total pancreatectomy anyway. Okay, those are the things. And when you are looking at enucleation, what do you think are its requirements? What are the kinds of tumors that are amenable to enucleation? And what is the kind of, sorry?
Insulinoma.
Yes, okay, insulinoma.
Basically, small size
Neuroendocrine tumors,
tumors.
yeah.
Yes.
Okay, what else? These tumors
Inflammatory,
cannot be
small
very
inflammatory
big, can they?
masses.
Yeah. Inflammatory small masses, you wouldn't probably do any resection at all, right?
Cystic neoplasms. Sir.
Sorry, cystic neoplasms, very correct. Pseudopapillary neoplasms. Any guesses on what size it should be for enucleation? Can you re-enucleate a large mass?
2 centimeters. Sir.
2, all right, fair enough. It's 3 centimeters. Okay, it's a local resection with healthy margins, usually less than 3 centimeter lesions. And these tumors cannot be really malignant. Either they must be benign or tumors with low malignant potential. NETs are like that, cystic lesions and solid pseudopapillary tumors. Morbidity is low, but pancreatic fistula is high, and what decides that is the proximity to the MPD. When you divide or make a hole in the main pancreatic duct, in the process of enucleation, you have a high chance of a fistula. That is what you must remember. So if you have a big hole after enucleation, which you should try and avoid, one of the things you should consider is drain that. Otherwise, you may end up with a pancreatic fistula. All right. Now you have other methods of dealing with it, but I won't go into it. But just mention one or two things that you can do to reduce the fistula formation. One or two simple measures. You must reduce the pancreatic secretion, right? How do you do that?
Octreotide.
By
Sir.
giving
Octreotide, sandostatin
yes.
analogs. And then to prevent the pancreatic juice coming out of this defect in the main pancreatic duct, and to facilitate its movement towards the normal area, which is the gut,
Stenting,
what do
sir.
you do? Stenting.
Stenting.
Do a pancreatic sphincterotomy and stent it, and that will sort out the fistula if you have one. Okay. So when would you do a central pancreatectomy?
Tumors which are localized only to the body of
Body
pancreas.
of the pancreas.
neck.
Obviously, they're bigger than 3 centimeters. If they're small, you would do an enucleation, right? And so you would want to do it completely. Yeah, you would do that. And this is the reconstruction that you can see. Okay. The head of the pancreas is retained. This is the uncinate process. Head is retained and you just stitch up the pancreas. Okay. what is the precaution that you take when you stitch up this?
It just should be inverted, sir.
All right. Even before stitching up the parenchyma, you have to do something very diligently. What is that?
Close the duct.
Correct. Identify and close the duct there. How do you close the duct? What suture would you use?
Unobservable.
Prolene, sir.
Yeah. All right. Yeah. For PDS or something, definitely not vicryl or
Vicryl, yes.
yeah. You must use a non-absorbable or a delayed absorbable and use a figure of 8 suture to stitch the duct first, and over it you can fish mouth the pancreas. You know what I mean? You can sort of cut a wedge and not just flat. Cut a wedge and then you can close it with again non-absorbable sutures, or you can do horizontal mattress sutures. If that tears through, what do? If the mattress suture tears through the substance of the pancreas, if it's very soft, usually it is soft in neoplasms. It's much better, much more amenable to suturing because of the fibrosis in chronic pancreatitis. But remember, here we're talking about neoplasm, so it will be a soft pancreas. How do you prevent the stitches from cutting through? Use platelets. You know what platelets are? Platelets? No?
No, sir.
These are little sheets. These are, you can use many materials, but these are little sheets that you have, synthetic sheets, which actually hold on to the thread. You can, it's very difficult to describe it, but you must, the cardiac surgeons use it all the time when they suture the prosthesis, valve prosthesis, because they are actually suturing a soft cardiac muscle. So it's similarly, you use these little sheets which hold on to the suture, and when you tie it, it doesn't cut through the substance of the pancreas. So look up platelets. Ravi, can we show them a platelet sometime when they're in the OT?
Okay.
Yeah, it must be available in Sagar OT. So,
Vortex or PTFE.
yeah. It's done on the Gore-Tex and it's a synthetic material. You cut it into little rectangles and thread your suture through it first. So that gets onto the posterior surface, and when you bring the two ends to the anterior surface, take a second pledgelet on the anterior surface and tie your thread on it. So it's a very easy way of making sure that your stitch doesn't tear through. And you use a raw Y to drain the distal pancreas. Okay. Now, as I said, these are the common indications: benign and low-grade neoplasm, same as enucleation, but the tumors will be bigger. And there are reports of 5-6 centimeter sized body tumors, which are amenable to central pancreatectomy. Please note that a 5 or 6 centimeter adenocarcinoma will by then have spread a lot. It doesn't in the body, it doesn't give you any symptoms. So most of these are inoperable when it is that size of a carcinoma. But these are cystadenomas and pseudopapillary neoplasms, which are amenable for central pancreatectomy. Okay, so the dissection around the neck is very similar to Whipple's. You have to get into the plane between the SMV and the posterior part of the neck. Defining the lower margin is very important. All right, and you can resect the tumor. You many times preserve the splenic artery and vein in this, and then you can resect the tumor. You can suture the PD proximally and put a loop of jejunum onto the distal part. Whenever you cut the major pancreatic duct or damage it, you can safely say one of the complications is a post-op fistula. Okay, I have quite a bit more to do. Can we stop here and do it in another class, or do you want me to continue? I may have another half an hour. I think it's better to do it in another class. What do you say,
sir.
Sanya?
Yes, sir. We'll take another class because I think most of us have little doubt, like most of the doubts that need to be discussed
All
with
right,
you, sir.
all right. Now, okay, we'll end this class here, but before we end, Ravi, comments up to this point, please.
I think there's a lot of clarification that you've given on every procedure.
Yeah.
Indicates the main technical steps and the complications. I think what surgery we should do for what, I think that is very clear. I think it's a very, very good plan.
Thank you. Questions and doubts so far?
Sir,
No, sir.
all of us had just one clarification, sir.
Yeah,
Like maybe in the next class, if you could just walk us through how cauterization is done
all right.
and how we approach the pancreas, like go along the gastrocolic ligament that you said, and then if required to go along the greater curvature of the stomach, till where do
Okay.
we stop, where, what all we like it, just like the surgical techniques, sir. If you can
Alright.
just walk us through that.
I'll
We'll
do
read
that.
and come, sir.
Read up
But
and come.
yes, sir, we will.
I have some of these
a
steps
little
when I talk
clarification.
about Whipples in the subsequent slides. And
Yes,
that
sir.
will become clarified. You know, I would have done, I was going to cover all that in subsequent slides when I was talking about
Okay, sir.
Whipples, but yes, we will spend time and cover that. Okay, next.
Yes, sir, yes.
Any
Okay.
other doubts?
No, sir.
All right.
Otherwise,
So thank
no
you.
doubts.
You schedule another class for this sometime, Sanya. And
Yes, sir,
we
yes, I
will
will.
then deal with distal pancreatectomy, Whipples, outcomes, complications,
Yes, sir.
and a brief note on how we deal with the complications. Okay,
Yes,
those are
sir.
the things
Okay.
that we
Yes.
will cover in the future classes. Okay, so
Okay, sir.
thank you very much and good night. I'll close the class here.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.
Good night.
Good night, sir.